discussion of a real situation, because we've been talking kind of theoretically about what is good addiction treatment and what to expect of good addiction treatment, and then we spoke about doing time versus doing treatment and change, how to make phases more function-oriented. And now we want to try to apply some of those principles to a real-life situation. Just a heads up that on Monday, if you haven't registered and you're available and want to register for the upcoming session, which is going to be on engaging participants in a self-change process. That's really looking at how do we start working with people to actually make positive functional change that's going to be lasting, and what's involved in good treatment in doing that, so that we're all aware of what to be looking for as a person moves through their treatment. And that pertains to this case in particular, because I think what Becky outlined in this case was really how things were not progressing and what could we have done differently. So Monday, April 4 at 1 p.m. Eastern, we'll do engaging participants in the self-change process, and then follow that up the next day with a question and answer session. But to get to the case today, and I don't know if Becky's on the line yet, but if you're on, Becky, we wanted to try to give you the opportunity, if you were comfortable, to actually interact live if you have a microphone on your computer, to participate in that way, or at the very least to chat and respond. Otherwise, I will certainly do my best to go through the case, and what I've done is put into the PowerPoint slides your exact case and highlighted in yellow things that I wanted to comment on. But again, if Becky's on the line and you are able to call in and be part of it, we'll make that arrangement. So this is a case about from Family Drug Court, where many people are concerned now, as about the heroin epidemic and the opiate epidemic that's going on. And this Family Drug Court has been in operation for almost 2 years, where the focus, of course, is working with families, primarily young women, attempting to reunite with their children, and they've become involved with the child welfare system, where their children have often been removed from their care. The reason I highlighted reuniting with their children is that is often a great motivator for people to want to participate in family treatment court, family drug court, because they want to get their children back. But it's always important to check out with the actual client why and what is the most important reasons they want to reunite with their children. I mean, we often assume from our own experience with our own families that, of course, why wouldn't a parent, whether it be a father or a mother, want to be reunited with their children if they've been taken away? And isn't it obvious that they're going to be very motivated to do that? Well, what I found is that that's not necessarily true, so that when you see somebody who's not doing well in their treatment, you can, of course, as we will discuss, look at what's going wrong. Why aren't they engaged? Why aren't we getting the outcomes that we would imagine they would want, which is to improve their function and to become better parents and to then demonstrate that they have solid skills, parenting skills, and a solid support system? Why wouldn't they want to do that so that they can make a good case for getting their children back? And then we see them not doing well in treatment, and we wonder why that is. And it could be that we've missed something in the assessment and the treatment, but it can also be that the person, the participant themselves, isn't trying that hard. And we, from our own experience, might say, why wouldn't they try so hard to get their kids back? Well, they may be ambivalent about getting their children back. Or the grip of addiction on their life is so powerful that that's what addiction does, is that we give up some of the most important things to us in terms of family and work and freedom and so many other things under the power of the grip of addiction, that it seems obvious to people who don't understand addiction that they would be trying as hard as they can to get their kids back. So one of the useful things whenever anybody enters into treatment in family drug court is to say, you know, what we've said, thank you for choosing to work with us, but what's the most important thing you want that made you decide to participate in this? And if they burst into tears and say, of course, I want to get my children back, they're the love of my life, and I can't think what I'd do without them, then you have some sense that they are really wanting their children back. But if they say, well, they made me come, well, why did they make you come? Well, I want to get my kids back. Well, how important is that to you? Well, of course it's important, but you don't get the affect and you don't get the reasons of why it's so important to have the children back. You can even play devil's advocate a bit with that sometimes. And we'll talk some more about this on Monday when we're talking about engaging participants in a self-change process. But you can play sometimes devil's advocate, not in a manipulative way, but to say, well, of course you want your children back, but, you know, doesn't that also interfere with your drug use? Doesn't that interfere with being able to go out whenever you want to go out? Doesn't that interfere with you having to take care of them when sometimes you know, would rather use something and you know, keep drugging, and doesn't interfere with partying, doesn't interfere with your friends. And you would do that in a way that would give them permission to say, well, yes, it does interfere. I mean, I sort of sometimes resent them. And so even at the very beginning of engaging a person in family drug court before you get to the assessment, it's good to really get a sense how strong is their drive to reunite with their children, because that will give you a clue of what to look for as you proceed into the assessment and into treatment. So Becky goes on to say they serve about 25 families, and they've seen 8 families complete the program since April of 2014. And they have basically a year to work towards reunification, and this is common across the country, that you know, times are being shortened actually, but usually a year is not uncommon, with, as she says, the possibility of 2 6-month extensions if it looks like the person's making good progress and you can make a case for their being continued treatment. And I think that's important to have in place to make sure that it's not just a year and that's it, black and white. But let me make some comments about this, because what often happens is when we say we have a year, what can too easily happen is that both the treatment provider and the client and the court can let things drift and sort of feel like, okay, well, they may come round even though they're not that engaged, even though they seem not to be doing so well and putting a lot of effort in. We've got a year to kind of really try to break through denial, to try to get them to see the supports that they need to develop, to try to get rid of any unhelpful relationships, to improve their parenting skills. And what I'm suggesting is that as soon as you're seeing somebody not doing well, even if that's in the first couple of weeks, not to ignore that and overlook it and sort of start thinking, well, of course it's early yet. We've got a lot more time. What I've seen happen too much is that people are allowed to drift for several weeks and even months, and we lose that valuable time to really notch it up, to engaging them and working with the leverage of the reunification with their children, and also looking very carefully at what have we missed in the assessment, what are we not doing in treatment, what are we not doing in terms of motivational work, what are we not doing in terms of looking at any leverage we have, not just the leverage of the children, but other sort of leverage, important, significant relationships or other family members, or what have we missed in terms of co-occurring mental disorders that may be making it hard for the person to engage. And so what can happen too easily is that when we think we have this year, that the person just starts drifting and not really being held accountable to doing good faith, collaborative work in treatment. Now, if somebody is working as hard as they can and it's clear they're having some difficulties, that's when as a team, the court and the treatment provider have to look at what are we missing? Are we missing a co-occurring disorder? And we'll review the 6 ASAM criteria dimensions in a bit as a way to look at when a person isn't doing well in treatment. Now, there are going to be some people who are working as hard as they can and are really in good faith developing change as quickly as they can, but just are overwhelmed with so many different problems, co-occurring trauma, difficulties with community supports, that you are going to need those extensions to really give this person a chance. They may be making good progress, but no person, especially if they've had years of drug problems, can just, bounce back in a year, especially if they have a lot of complex other issues to deal with. So it's good that we have those extensions, but those extensions shouldn't be used just to let a person drift some more. They should only be used if there's been demonstrated real good faith effort and the person is making progress, but they're just not making it as fast as we would like, and yet they're working as hard as they can, and so the extensions are justified. What I'm saying is that in that year's period, if we're doing robust treatment that is demonstrating real change and then expecting good faith collaborative effort from the participant, you can really define in that first 12 months whether somebody is really trying hard to get their kids back or whether they really are very ambivalent about getting their children back and therefore are not putting the effort into it. And so we shouldn't let that person do time. We should call the question on that sooner by sanctions and by relooking at the person's commitment to really doing treatment. But of course, in that process, we have to also be making sure we're not missing something in the assessment and improving the treatment, which would give the person a chance of a better outcome as well. Now, what Becky goes on to say is we are a phased-based program that uses a series of incentives and sanctions to promote advancement towards the ultimate goal of reunification. And of course, we do not use jail as a sanction. And that's pretty typical. We talked about that in the last session. My question is, though, are the phases based on time or are they based on functional change and demonstrated effort in terms of collaborative treatment? If they're based on time, again, that's where we run the risk of a person kind of just sort of complying and going through certain phases, and then we're promoting them through those phases, but it's not based on real functional change. I'm just going to pause here for a second to see if there are any questions or comments, so that if anybody has any questions or comments or disagreements as they're going on, please feed those back. We want this to be as interactive as possible. And especially if Becky's on, if she has any questions, we want to make sure this is helpful to her since it's her case. Do we have anything yet?
Hi, David. It doesn't look like we have anything
Okay.
at this time.
All right. So let's keep moving. So 3 weeks ago, though, Becky says they had their first death by overdose. And of course, that's devastating to the team, to the family, to any significant others of the person. And the young woman had had multiple treatment and aftercare episodes. And whenever any client dies in any situation, that's always a very disturbing situation, because we all, of course, think, well, what did we miss? What could we have done differently? Did we do everything we could have done? But it's also a reminder that addiction is a deadly disease, and one of the deadliest that, as we know from all of the news we're hearing about the overdoses with opiates and heroin, death is a real thing. So while we don't just shrug it off and say, well, that's just part of addiction, we do have to remember that we're dealing with a deadly disease, which makes the importance of doing robust treatment and expecting real change and making sure that if a person is not progressing, that we catch that way sooner rather than later and reassess why isn't treatment working, and to what degree do we need to change the treatment plan, to what degree do we need to get consultation and find and make sure that we aren't missing something to get the best outcome. So this says the young woman had multiple treatment and aftercare episodes. Well, whenever I see multiple treatment and aftercare episodes, I'm always interested in, well, what worked and what went well with those multiple treatments, and then what didn't work and why were there multiple treatment episodes. Now, the fact that there are multiple treatment episodes doesn't necessarily mean that treatment's not working. We're talking about addiction like other chronic diseases that relapse and flare up and may need multiple treatment episodes. So just the fact of multiple treatment episodes is not a problem in and of itself, but we should be looking and learning from that right up front in the assessment as a warning flag that here's a person who hasn't done well before. And have they not done well before and had multiple treatment because we've just been doing the same kinds of treatment? What have the treatment episodes been, and were they all using the same model? Did they all just repeat a program-driven residential treatment or something that the person kind of just skated through and went to aftercare? Now, even the word aftercare is I want to make a comment about, because if we think of real treatment as being intensive treatment or the residential level, and then aftercare is sort of you know, just some groups that people go to on a routine basis, the ASAM criteria would really say that there's no aftercare in the sense of using aftercare meaning after professional care, because what is aftercare for diabetes treatment, or aftercare for schizophrenia, or aftercare for depression treatment? Aftercare, if a person is really needing continuing care, that is really a treatment situation where they should be coming in and being monitored in a very close way, especially if they aren't doing well. So that we want to look at making sure that these multiple treatments were actually treatments that were robust and where they were coming in for a good evaluation and full treatment. Just excuse me a second, there's somebody at my front door. I apologize for that, but I'm here on my own in my office here. So what we want to really look at is when people have had multiple treatments, that's a warning flag that this is a particularly important case to assess. And in this case, she actually had the children returned but then removed. So that tells us also that there's a problem here. that we want to really pay attention to. So I don't know, Becky, if you're on the line and can give us any feedback. Do you know if the multiple treatments were the same sort of model, you know, perhaps going into a family court mandated treatment where they put her into a mommy and me program for a year or several months, and she kind of went through the same kind of treatment program? So that's a question. And Monica, do we know if Becky is on the line?
It doesn't look like it, no.
Oh, okay. Well, that's a pity. All right, so for all of us listening, that would be the thing to look at. If you get a person with a history of multiple treatments, but they have all been the same kind of mandated treatments and the same kind of modality, that is particularly a problem, because what might have happened is that each of those treatments kept missing important things like co-occurring trauma or mental disorders, or even didn't work with the motivational aspects. Now, what it says next, which again is also along the same lines, is we could tell we were losing her. She was dropping urine drug screens. She was, you know, not, in other words, making good progress, and they could tell that. And the first moment that you notice somebody's not progressing well and making good progress, what we have to do is to reassess and work out, why is that happening? What are we missing in terms of her assessment? And if we quotes are losing her because she's not participating in a good faith way, that's when you would have to say to her, it looks like you're not really participating in treatment. We have to recommend some kind of sanction. I'm not calling jail, but you have to talk about some sort of sanction to get her attention that she's not actually in compliance with the family court order to do treatment. And she might say, well, I'm here, aren't I? Well, that's not really doing treatment. So we'll talk in a little bit about how to reassess things when we see somebody who we're, quotes, losing. And then the next thing was she had completed treatment and intensive outpatient, but wasn't engaged in ongoing sober support. And in addition, had entered into a new relationship with a young man who was also suffering from addiction and not staying sober. Now, the importance of why I highlighted this is because when we talk about somebody completed treatment and intensive outpatient, but wasn't engaged in ongoing support and then involved in not good relationships, my question is, what does completed treatment and IOP mean? Because we shouldn't be completing people in treatment or graduating them if we're just talking about that in terms of time function. One only completes a particular level of care when you've improved to such an extent in function and progress that you're able to move to a less intense level of care. So when we even use the word completed treatment in a chronic disease like addiction, we have to make the distinction. Are we talking about she completed some mandated length of stay and then went on to, quotes, aftercare? And the disturbing thing about that is what we've been talking about in this whole webinar series, is that we want to move from an emphasis on completing treatment, meaning completing a set amount of time or going through certain phases, to moving to, has the person improved, in this case in their parenting skills, in their recognition of who they shouldn't be hanging out with, in their recognition of how do I demonstrate a good income method other than doing illegal things like drug dealing or prostitution or something? How do I demonstrate a good housing supports that I'm safe to have my children back and that the children will be safe in my care? And if we see somebody losing it and not really engaging in sober supports, that's the message she's not doing well in treatment. So there's no way that you'd want to complete somebody in treatment when it's clear they're not making the kinds of functional improvements that would serve to demonstrate that they are indeed a good parent and safe to have their children back. But again, it would ideally be good if we could talk with the treatment team and the court team and understand what they meant by that she had completed treatment. If completed treatment means time, well, then that's why we have to move away from thinking of treatment as time-based and much more focused on individualized, demonstrated improvement. Now, what Becky says is that this is common, that many of the young women get involved and enmeshed and attached with men who are not helpful for their recovery and sobriety. And many of the families of these women are also fractured and toxic themselves. So, it's understandable that they look for a relationship, because any relationship is better than none. And that being so, and that we know that about the population we're serving, makes it all the more important for us then to be addressing what would be in ASAM criteria dimension 6, recovery environment, and then also dimension 4, their readiness to change, to see to what degree we can actually engage them in a process of looking out for the best kinds of relationships they can have. Now, to go on with the case, a full alcohol and drug assessment was done at the time the participant was referred to the program. All participants are screened for severe mental health conditions that may prevent participation in the program. For example, they can't accept sex offenders into the program. But what Becky talks about here is that in many cases, mental health conditions are often not previously diagnosed, or in the course of treatment, mental health issues come up, things like borderline personality disorder, and I'm sure things like trauma come up. And these are significant issues, especially in women who have developed addiction, and men too, but especially women, sexual abuse, physical abuse. These are important co-occurring conditions that can affect treatment and affect the ability of the person to develop the parenting skills they need to be safe to get their children back. So Becky says it's a fine diagnostic line to walk, because they want to identify and refer families to treatment as quickly as possible because of the timeline of the 1 year for a reunification decision. But it's also clear that they may be missing some key indicators along the way that may actually benefit most from the program. So the fine line is, how do we not exclude people who have co-occurring mental health issues, because that's what needs treatment? And if we do identify those up front or in the course of treatment, are we making sure that we're giving that person good co-occurring integrated disorders treatment, co-occurring mental and addiction treatment? What Becky goes on to say is that they partner closely with community addiction services who specialize in women's recovery. And there are, of course, housing where the mother can live with their young children, so mommy and me type programs. But she's saying they too are overwhelmed with the population because it's a complex population to work with, but fortunately they are doing some medication-assisted treatment in addition to trauma-focused therapy and other sorts of supports. And that is the right thing. That's good that those community addiction services are looking holistically at those co-occurring mental disorder issues and making sure that if medication's needed, that that's part of the treatment plan, and making sure that if trauma work is done, that's included as well. But this is just emphasizing again that we're dealing with a complex population where as soon as somebody doesn't look like they're doing well and we're, quotes, losing them, that's all the more reason to step up a reassessment and look at what is actually going on so that we make sure we're not missing anything in terms of co-occurring disorders. And if things aren't going well, some outside consultation may be important to the treatment provider to get a fresh pair of eyes on that. So Becky asked, what are we missing, especially in the case of a woman who overdosed and we lost her, because in addition to this tragedy that they had recently, we have 3 or 4 other women who have run out of time to reunify. They go in and out of treatment, they relapse, they return, and then they complete treatment and IOP and then run into problems back in the community. Again, though, I'm emphasizing what does complete treatment and IOP mean? If they are not doing well, it shouldn't be a matter of completing them. It's a matter of looking at if the person's engaged and doing all that they can to make progress in their treatment. That's when we would want to really advocate for some extended time to give them a chance to really make the changes in their complex issues that they often present with. Even if Becky's not in the line, if others have the same problem where people seem to complete treatment but don't really do well, we should have a discussion about what completing treatment and IOP actually means. Now, another good feature that she mentions is recovery coaches, especially when someone is at the end of treatment, to help them adjust to returning home. This raises a couple of issues. If we are putting people into long-term Mommy and Me residential programs, and often up to a year, but they aren't being given a chance to get on the psychological treadmill. By that I mean, once a person looks like they're relatively stable, we want to actually put them in not towards the end of 12 months, but sooner rather than later, give them a chance to try out their skills in the community. This is why we need a continuum of care for people, and what often happens is, especially in family drug court, people get admitted to a long-term residential Mommy and Me program for several months, where the phases are often several months before they can actually even go to a more outpatient setting. I remember the sad story I had of another client, sort of the same story. Children had been taken away, but then she was given a chance to go into treatment. She was in a residential program where they said, this is a 2-year program. This was in the days when they had 2 years. And you have to be in certain phases before you can look for a job. You have to be here at least 6 months before you can start looking for a job and looking at housing in the community. Well, she had done quite well earlier than that. She was at 3 or 4 months and she had gained a lot of skills. She was stabilized. She was ready to stretch her wings and to really start looking for work, looking for an apartment, and she wanted to do that as a way to demonstrate that I have an income, I have a safe place to bring my children back to. And the program said, no, you can't do that because you're not at that phase yet. And if you go out and try to get a job or to start trying to build community supports, we will tell the court that you are not in compliance with the program and therefore even jeopardize further you getting your children back. And so she was at a dilemma about whether she just has to sit tight and do time to go through certain phases rather than to actually build the very support she needed to demonstrate that she could be a good parent and support her children. So again, we don't have the, Becky, to discuss this with us, but when we talk about recovery coaches, especially at the end of treatment, I would say we need to bring recovery coaches in sooner rather than later to help people start developing those community resources. And as soon as somebody's looking more stable in more intensive levels like residential, that we give them a chance to see if they are actually able to stay away from those unhelpful relationships, to see if they are actually able to develop a support network, to see if they're actually able to develop work skills. And as she says, our participants seem to lack so many things at the same time: housing, financial resources, family support, transportation. That's what I mean about we have to give them a chance before the year is up to see if this is a person who can deal with those kinds of real-world community issues, rather than to, quotes, graduate them after many months in a very safe environment, only to have them go back to relationships that blow up, and then they're back again, and there we see the multiple sorts of treatments and the multiple failed attempts. Becky mentions that she's appreciated my work and has a copy of my Tips and Topics book, and also uses some of the journals from the change companies. And I mentioned that just because I want to alert you to some of those resources that you can have for ongoing resources. So I'll tell you a little later on how you can sign up for my free monthly newsletter, Tips and Topics, if you want to get that, and also the book she's referring to. This, again, is not to be selling you stuff, but because these cases are so difficult that you need some ongoing resources to help you begin to make these changes in our system and in our treatment to really rethink and redevelop our whole system to address these kinds of challenges. So again, let me pause to make sure, do we have any questions, comments, or disagreements, Monica?
We do have a question from Mr. John Zoller. He says,
okay.
How is this treatment approach significantly different than the approach that should be taken with anyone else entering a treatment court program? Motivation for program entry, prior treatment attempts, toxic relationships, all are central to any treatment court program.
That's a good question, and you are right that all of these principles are the same. I think the difference, and I don't, we don't have the chance to talk back with Becky, is that what I've seen in terms of family court programs, especially if working with community programs where they have specialized mommy and me type programs, that not infrequently, these parents are mandated to many months in a residential treatment setting, and that also happens with other clients where they're mandated residential. And what we've said before is that we shouldn't be mandating people to a particular level of care and a particular length of stay and leave that to the assessment to individualized treatment using a continuum of care. And that should be for all people, but especially what is different, what I've seen in terms of family court, is that they're often mandated to residential treatment for many months, and phases are constructed that don't give a person a chance to test out some of these more community supports. And so there is some difference there between some other drug court clients who maybe have more flexibility in the level of care that they're in. If that didn't answer it, though, please come back at me. But you're right that in general principles, engagement, assessment, reassessment, tracking progress, tracking engagement of the person, that applies to all drug and problem-solving specialty courts, including family court. The main difference is in this mandating sometimes parents to long-term residential, which burns up the time in that year before a person can really try out some of these other community aspects.
Great, thank you, Dr. Mee-Lee, and looks like that's the only question we have for now. So.
All right, so Monica, please interrupt me if we get something so that we
Absolutely.
can catch it. So let's apply this then. So in what we're talking about is, in this case, when we're looking at an individualized treatment cycle, and you see the progress part there, if you think of this as a clock at 9 o'clock, whenever you see that we're losing the client, that was something that Becky said, or we see them not making progress, and I'm saying if that's even in the first week or two, we don't want to be complacent to say, well, we've got the whole year, or we've got another 90 days, or they're mandated to 90 days or something. Let's just sort of see how they go. That's really the signal to say you have to immediately go back to the assessment and say, what have we missed in the biopsychosocial assessment? And is there a new problem that we have to change the treatment plan? So this should be a dynamic living process that is really tracking whenever somebody is not functionally improving or not in good faith engaged in treatment, that we want to assess what is it that is the problem, what are we missing? It could be that if they're in an outpatient setting, they're still using something on dimension 1, which is making them, of course, not even be abstinent, and that they are, you know, having trouble. Or if they are not using, they're having still some craving from withdrawal. They're in withdrawal, and so they can't concentrate as well. It may be that on dimension 2, they're not doing well because there's a chronic pain problem we've missed, or that there is some other physical health problem which is distracting them from full recovery. It may be on dimension 3 that there's a co-occurring trauma issue, or co-occurring mental disorder, or borderline personality disorder, or some other antisocial personality disorder, or depression, or anxiety, or even psychosis, or bipolar disorder that is making it hard for them to engage. And so that's a person who's going to need immediate help in looking at, do we need to do more co-occurring disorders work? If we're, quotes, losing somebody, is it that their readiness to change has fluctuated? When they came in, they were very focused on wanting their kids back, but now they're getting second thoughts about that as their addiction craving increases. They start thinking more about addiction than their children. And that could be a fluctuation in their stage of change. Or we assumed that they wanted to get their kids back, but we didn't really dig deep enough to see, is that really true, or are they just kind of going through the motions? On dimension 5, is there a real problem with cravings to use, or you know, problems with really having triggers and temptations to use, and they're just so distracted in that sense? And then the important dimension of recovery environment. Are they in some kind of unhelpful relationship? Are they the victims of physical or domestic violence, or partner violence, or intimate partner violence? And do they have any family or significant others who could be a support to them? Or are they so estranged from family or significant others? What about their financial situation? Do they have any job skills? Do they have a safe living situation? All of these things should be assessed up front and be worked on from the beginning, not seen as kind of aftercare planning issues. If any of these issues, any of these dimensions have problems, that should influence the particular treatment plan. And then are there any criminogenic factors that we have to take into account, which, as you can see, then apply and can be subsumed under the ASAM criteria dimensions, because we're trying to develop an individualized treatment plan with them, And as you can see under medication, medication-assisted treatment might be needed, or as I've said before, think of it as medication in addiction treatment, not medication-assisted treatment, because some people need medication, some people don't. So again, we're looking at this particular case, as she was not doing well. This is what you would want to be looking at. Have we missed a dimension 4 issue? And if that shows up very early on in treatment, we have to deal with it right then. If she just seems to be sitting there and not participating, it could be a dimension 4 issue, or it could be that plus a combination of other issues. Is she needing medication? Is she not involved in self-help, mutual help group meetings? And what is her block to that? It may be that AA isn't the best program for her, but a community of faith. Or does she have do better with SMART recovery? So we have to assess each of these areas, the dimensions, and then change the treatment plan, and then look at level of care. Because if a person is mandated, and this is why we would really encourage drug and other courts and judges to mandate assessment and treatment adherence, not mandate a residential mommy and me program for 9 months or something, because we want to put her in whatever level of care is needed, and then really make sure that if she has reached some level of stability in that level, that we then test her out by putting her into a less intense level. So I'm not going to go through all the levels of care again, but just a reminder that it should be a continuum of care, and to go back to this decision tree. What does the client want? You're being referred here to get your children back. Is that really what you want? If so, what would be the most important thing that you are willing to work on? Why is it that you want your children back? What's the most important thing you miss? So a lot of renegotiating what the treatment contract is, and that is not just with parents getting their children back, but anybody. We want to make sure that we assess any immediate risks in the 6 dimensions. If there are, you take care of that. If not, we go back through the 6 dimensions in the initial assessment to make sure, does she even have a diagnosis of a substance use disorder? And if so, which dimensions then are a priority to work in, by going through and looking at severity and level of function to identify which dimensions are a priority within that dimension, what is the particular focus, so we can identify what services are going to be needed, and the dose and intensity of those services will tell us what is the least intensive but safe level of care, and then how they're progressing tells us when we need to change the treatment plan. So in this case, whenever we hear the words completed treatment and IOP and aftercare, those are always words that I'm concerned about, because if a person is not doing well, as happened in this case, they shouldn't have completed treatment. They would need some ongoing services. And then we would want to know, did they actually move through this decision flow through levels of care, or was she stuck in certain phases based on time? Because that's how you find out sooner rather than later in that 1 year, if this really is somebody who's not really wanting to have her children back, and therefore we should call the question and not pretend to be doing more treatment. Or is she working as hard as she can in good faith, but has so many other complex issues that she needs more time to be able to develop those sorts of skills? And by going through this process of reassessment and looking at the 6 dimensions to make sure we haven't missed anything, you will identify pretty early on, as you work together as a court team and a treatment team, whether we have somebody who is able to develop the parenting skills to get her children back, or whether things have gone too far that reunification wouldn't be safe and is not possible, because this may be somebody who is so chronically along in their addiction that they've passed the point of developing sufficient safety that would make reunification possible. And that for this particular child anyway, or children, reunification may not be possible. Not to say that she couldn't, or he, if it's a father, couldn't at some later point enter full recovery and then be safe as a parent for a future child. Now, I just want to mention some of these resources that if you are wanting to get tips and topics, my free monthly newsletter, you can go to www.tipsandtopics.com. If you want to get the book that Becky was referring to, you can contact the Change Companies. If you want to read more about the ASAM criteria, we have a special chapter in there that is specifically around parents with children in treatment with them. So these specific issues that come up in family drug court, we address as one of the special populations. There are 4 populations in the ASAM criteria that we highlighted, and the one that would refer to family court is parents or prospective parents receiving addiction treatment concurrently with their children. So, as I said, like in a Mommy or Me program. So there's a whole chapter on applying these principles to parents with children in treatment with them. And then if you want to look at some of the interactive journaling and evidence-based practice around workbooks for clients, you can go to the Change Companies for that. Now, on the ASAM criteria itself, go to asamcriteria.org, and then there are e-training modules as well. So again, let me check to see if there are any questions or follow-up comments from anybody.
At this time, there are no questions.
Okay. And I want to just finally reiterate some of the questions for all of you as you look at your cases. The things that we've learned from this important case is, again, look at what you do to engage a person in terms of what is it that they really want. For those of you who have other family court problems or clients, I mean, please look at whether you have a phased-based program based on time and whether people are being mandated to a particular level of care for a particular length of stay. This is true across the board, but in family court, if you have a program still that is mandating people to a parents with children residential program in long-term residential for 6 or 9 months, that often burns up the 12 months period with a person not being given a chance to develop those community resources, and then things blow up too easily once they're outside of that much more controlled and safe environment. If you are beginning to involve people with co-occurring disorders, that's great, but that also means that those co-occurring treatments need to happen within the continuum of care, not just in residential. If you are involving recovery coaches and peer counselors, that's great, but you start involving them sooner rather than later so that there's a focus on community resources from the beginning, not seen as sort of aftercare planning. If you do have any other family members involved who are not toxic, please involve those sooner rather than later. And if in this case, where we did have a case of actual overdose death, it's critical to involve the family, even if they weren't involved in the treatment, which we hope they would have been and reached out to, but even if they haven't been involved in treatment, that they be contacted to really give them supports, because they will have similar reactions often as the treatment team and the court team. That is, of guilt or of feeling regret or wondering what could have been done differently, or sometimes even anger at the client. But they need an opportunity to work through those feelings, and we need to reach out to give them support as well. The final thing that I would say is that the similarities of family court clients are all the principles we talked about. And so if we start moving away from time phases to function phases, we will have an opportunity to identify when things aren't going well and make changes before we run out of time. And then the other aspect is, as soon as somebody is stable at a particular level of care, we want to loosen up the structure to give them a chance to test out whether those skills are really incorporated in real change. Now, if you do that and things trip up, you know, they recontact a relationship that you thought they had given up, or they even actually use, that's not a signal that they need to then go back into long-term intensive treatment. You want to just assess what went wrong, because you don't want to immediately, there's one poor outcome, put them back into more intensity unless that's really what's needed. And it may be needed if somebody said, I got out there and I just got overwhelmed, there's no way that I can do this without more structure and support. Well, then you give them that structure support. But if they made a mistake and contacted somebody that they shouldn't have contacted and hung out with them and used, and they're now saying, I can see I really have to stay away from that person, well, then you want to give them a chance to test that out again and not just say, well, you failed at that, so we're going to pull back and put you into more residential. If they see the error of their way and are willing to then go to more meetings and to do some other things to make sure they stay away from that person, get a restraining order or something, then you want to keep them at an outpatient sort of level, because you want them to keep developing those skills when you have the time before the reunification clock runs out. That's the point. All right, I think we're out of time. No other questions or comments, Monica?
No other questions or comments.
All right, so if anybody thinks of something else, you have my email address there. Feel free to email me or contact me offline, and we can do that. And a reminder again that our next session will be Monday, April 4, engaging participants in a self-change process, and then a follow-up the next day, Q&A. That's at 1 p.m. Eastern. Thank you very much, everybody.
Mee-Lee.
Thank you very much, Dr. Mee-Lee. This is fascinating. So we'll look forward to talking next week. Thank you, everybody, for joining in.